Okay, thank you very much. Okay, today we will discuss, regarding the diagnostic evaluation of platelet disorder and its related investigation. And mainly for today's, we will go into inherited causes of functional platelet disorders. Okay. As you all know, the thrombocyte or platelets are inverted cells derived from the megakaryocyte by process of megakaryosis. And this process will take a maturation around 4 to 5 days and around 10 power of 11 platelets are produced every day. And the production can be increased during the increase of demand. And this platelet production is regulated by thrombopoietin, which majorly produced by liver. Around 1/3 of total platelet mass are sequestrated in the spleen, with lifespans around 8 to 10 days in peripheral blood in vivo. Okay, so in terms of destruction of these platelets is basically by monocyte macrophage system, in particular in the endothelial system. And during the resting phase, basically the platelet are small and discoid in shape with a size ranging from 2 to 4 micrometer. Okay, and the platelet concentration in blood actually varies between 150 to 400 times 10 power 9 per liter. And as you all see in this slide, that I just to show the cluster or change of platelet that are shared from the megakaryocyte and carry off into bloodstream into our peripheral blood. Okay, so mainly when we talk about platelet function, basically the main function of the platelet is the formation of the mechanical plaque during the hemostatic response to vascular injury. And this immobilization of platelet at the sites of vascular injury require a specific interaction, while those iteration basically start with platelet adhesions and platelet activation and respiration and amplification, as well as the platelet aggregation until they form a soft platelet plaque. Okay, so apart from a key role in the hemostasis, vasoconstriction, and this platelet also involved in inflammations, host defense, the promotion of the atherosclerosis, and tumor kill and tumor growth in patients with cancer. Okay, platelet play a key and complex role in primary hemostasis, whereby this platelet needs to bind collagen at the damaged vessel wall and to bond membrane factors through various surface receptors. Right. And the local prothrombotic factors will actually activate the platelet, and this platelet will change its shape, and they start to express glycoprotein or their surface proteins. Okay, and after that, what they do basically, they start to release the contents of this their various granule, which serotonin, ADP, and various other protein, which actually promote for the platelet activations. And these activated platelets will start to extend their philopodia, and these again will promote the other platelets to come into platelet aggregation processes, which ultimately forming a platelet plaque. Okay, again, as we all know, when we talk about a platelet disorder, basically we will talk about whether it's functional problems or qualitative problems, or it is because of reduced in number or due to quantitative problems. And basically, the most common that we are already we are known actually acquired causes of a problem compared to inherited one. But today, what I actually try to expose to all of you is more toward inherited causes, because I think that we need to also know about the inherited causes in a quality platelet disorders. So, okay, platelet actually have a complex structure comprising a multitude of molecules and protein, and any malfunctioning of this glycoprotein or this protein actually can give rise into a specific disease. Okay, for example, when you have abnormality towards glycoprotein 2B3A, then you will have a Glanzmann thrombasthenia. Okay, and if you have antibody abnormality towards glycoprotein 1B5 and non-complex, then you have a Bennett-Fodder syndrome. What about abnormality towards GP4, GP6? Okay, these all abnormality will give rise toward specific diseases. Okay, right. So platelets participate in hemostasis by adhering to exposed subendothelial matrix, and then they start to spread onto the subendothelial surface, and then they become activated. When they become activated, they start to release the content of the storage organelles, and subsequently they start to promote other platelets to come to that particular area and aggregate to each other. What I showed you here is basically what is the platelets look like during the resting phase, and what is the platelets is look when it start to activate it. Okay, it start to extend their philopodia. Okay, before they release the granules. Okay, so when we talk about platelet dysfunction, functional platelet dysfunction, again, we'll talk about normal.
We can't hear you, Dr. Safarina. And can other people hear Dr. Safarina? No.
Tak dengar, Doktor?
Tak dengar kan?
Tak ada. Just the presentation is on.
You can continue, Dr. Safarina.
Okay. Okay. Right. Okay. Sorry for the technical problems. Usually, dekat GSM ni, kalau pukul 3 lebih, dia start dah ada problems. Kalau hari Khamis. Sorry lah. Okay, now we go to about the disorder of platelet adhesions, where I will discuss regarding the abnormality of platelet receptors. Okay, basically platelet adhesion to the subendothelium need the interaction of the platelet receptor with the subendothelium, with the collagen, with the fibronectin blood components, and also through the bridging effect of the von Willebrand factors. There are a series of receptors have actually been identified, and the most important receptor are actually GP1B9, okay, and also alpha 2B1, which previously known as GP1A, 2A, right? And the alpha 1B1 receptor, alpha 2B1 receptor is one of the receptor on the platelet surface that binds collagens and is a member of the integrin beta 1 subfamily. And the other receptor towards collagen, as I said earlier, is GP4 and GP6. Okay, and binding of this molecule to this receptor leads to subsequent binding to other receptors, which serve to reinforce adhesion and generate intracellular signal such as calcium mobilization and protein phosphorylations. Okay, one two of disease that I will talk today, basically because of abnormality of the platelet receptor, is Bennett-Sollier syndrome. Okay, BSS basically is relatively severe bleeding disorder. It's caused by qualitative and quantitative defects in GP1B5 9 complex, which is for 1 milligram binding sites. Okay, and this patient will have the mode of inheritance of this problems basically is autosomal recessive disorder, with a few exceptions of autosomal dominant disorder. Okay, and patient with these problems usually have a giant platelet on FVP. You can also see that this patient may have mild to moderate thrombocytopenia, and at the same time they will have a prolonged bleeding time. Okay, and patient with this problem we have a decreased platelet survival. Okay, for the platelet aggregation, there will lack of aggregation induced by ristocitine, and this not corrected by addition of the normal plasma. And towards other agonists, basically they have a normal aggregation, and this patient will have a mucocutaneous bleeding. Okay. Bennett-Sollier syndrome is due to basically a molecular defect, whether it is due to frame shift or deletions and or point mutation, which can be seen in GP1BA genes on chromosome 17, or you can see in GP1P on chromosome 22 and GP9 on the chromosome 3. And the diagnosis of this Bennett-Sollier syndrome basically is based on the demonstration of this deficiency of this particular protein by flow cytometry. Okay. What about platelet type 1 Willebrand disease? Okay. This is also one of the example of the abnormality to the receptors. Okay, platelet type 1 Willebrand disease or pseudo 1 Willebrand disease is actually not caused by defects of 1 Willebrand factor, but it was a gain of function, the phenotype of the platelet GP1B alpha. Okay, the mode of inheritance of these problems basically is autosomal dominant, and it caused by a gain of function missense mutation of GP1B alpha associated with amino acid substitution within the sulfide bond double loop region at GP1B alpha. Okay. The abnormal receptor of this glycoprotein has an increased avidity for 1 Willebrand factors, leading to the binding of the largest 1 Willebrand factor multimoles and cause their clearance from the circulation. And as we all know that high molecular weight 1 Willebrand factor are very the most hemostatically active. Their loss will associated with increased bleeding risk, like in type 2B 1 Willebrand disease, which is, but this type 2B 1 Willebrand disease is a gain of function abnormality of the 1 Willebrand factor molecule. Okay, this is a difference between these two. So in the presence of the hypersensitivity of the platelet toward ristocytin in low dose ristocytin threshold, then you need to think about these problems. Okay. And for the diagnosis, and basically for the confirmation of the diagnosis is made by genetic study. Okay. So this slide is just to show you a case which previously mislabeled as type 2B warm liver disease, but after the manipulation or by doing the RIPA mixing threshold, then we see that actually this case was mislabeled as type 2B von Willebrand disease. Actually, this patient have a platelet type von Willebrand disease. Okay, so what happened in this test? We actually do a mixing of patient platelets and patient plasma. Okay, and then we have a patient platelets and control plasma, and then we did a control platelet and control plasma plus the control platelets and patient plasma. What happened is in these cases, basically the tube that having a problem is the tube which due to which contain the patient platelets. Okay, this means that the problem is from the platelets. It's not from the plasma. Okay, from that, they actually do a genetic testing and confirm the diagnosis of platelet type von Willebrand disease. Okay, right. So other than that, we also have a disorder of platelet signaling transductions. Okay, platelets that actually adhere to subendothelial surface will become activated and begin the production and release of several intracellular messengers which modulate a series of platelet response such as calcium mobilization, protein phosphorylation, and productions of arachidonic acid. Okay, and the activated platelet will release their stored substance in the granules, and they start the recruitment of additional platelets leads to the formation of the primary hemostatic plaque. So basically, several signaling mechanisms are involved in the process, and any specific abnormality in this signaling process may be the basis of platelet dysfunction. Okay. Apart from platelet receptor problem, signaling problem, we also have a disorder of platelet aggregations. Okay, as you all know, the platelet aggregation basically defined as the interaction of the activated platelet with one another and occurs after the adhesion of platelet to the wall of the injured blood vessels. After the activation of the platelet and release production. Okay, and basically under the disorder of platelet aggregation, there are many problems that can happen, and some of we can actually classify into maybe because of defect of primary aggregations, or maybe because of defect of selective impairment of platelets receptors. Okay, maybe because of defect of secondary aggregation. Okay, defects of primary aggregation example is Glassman thrombasthenia, selective impairment of platelet receptor, maybe because of ADP receptor or adenine receptor, or defects of secondary aggregation. You can see in storage pool disease. So for defects of primary aggregation that I want to discuss it here, the common one is Glassman thrombasthenia. Okay, Glassman, as you all know, that is a congenital deficiency or dysfunction of the glycoprotein 2B3A. and which is the receptor for fibrinogen, which is responsible for mediating platelet aggregation. Okay, it is basically autosomal recessive disorder that manifests in lifelong mucocutaneous bleeding. And in patients with Glassman thrombasthenia, basically the bleeding time or platelet function screen test result will be abnormal. Okay, there will be no aggregation with ADP, collagens, epinephrines, and arachidonic acid, whereas the viscosity-induced aggregation is normal. Okay, when we talk about Glassman, basically Glassman can be classified according to the amounts of glycoprotein that they have. Type 1 is around 0% to 5% of normal. Type 2 is around 6% to 20% of normal. And the variant disease, basically a qualitative abnormality of problem, which is they have a 50 to 100% of normal with abnormal fibrinogen binding. Now we go to selective impairment of platelet receptor. Basically, you all know that on the platelet surface, there are actually different type of ADP receptor. Okay, the other two that we will discuss again today is 2G protein couple receptor, which is P2Y1 and P2Y2. P2Y1 receptor is responsible for the shape change of platelets, and transient platelet aggregation give rise to centralization of platelet granules and the forming of the filopodia, okay, whereby the P2Y12 receptor is involved in amplification of the response and the stabilization of the platelet aggregates response to ADP. Any defects of platelet ADP receptor can cause bleeding disease. Okay, there are a lot of drugs that that were produced today. One of that is P2Y12 receptor inhibitor. Okay, for the defects of secondary aggregation, actually, when we talk about this aggregation, secondary one is more common compared to primary aggregation disorder. And the most common in this category are the storage pool disease syndrome or storage pool deficiency syndrome, where you have a dense granule storage pool deficiency, or you have alpha granule storage pool deficiency, and you can have a combine between these two. Okay, example of the dense granule storage pool deficiency is non-syndromic dense storage pool deficiency, Hermansky-Pudlak syndrome, Chidia-Hikasi syndrome, TAR syndrome, and Waspa-Aldrich syndrome. For the alpha granules, there are actually gray platelet syndrome, Quebec platelet syndrome, and so on and so forth. Okay, basically, dense granule that you see in a platelet, they actually have ADP and serotonin, while the alpha granule have many other more protein, for example, factor V, fibrinogen, von Willebrand factors, and so on and so forth. Okay. So anything abnormality to this granule can give rise to a specific disease in the particular patients. So now we go to dense granule SPD. This dense granule SPD basically may present as an isolated platelet function defect or associated with congenital disorders. Okay, characterized by a variable degree of bleeding diastasis. Okay, and they can have a mild to moderate bleeding time, which inversely related to the amount of ADP and serotonin contained in the granules. They also can have abnormal platelet secretion function, and also around 75% of cases had impaired platelet aggregations. Okay, and patient with this problem, we have a decreased level of ATP, ADP, serotonin, calcium, and pyrophosphate. Okay, the diagnosis is based by Lumi aggregometry, which tests platelet aggregation and secretion as well. Other than that, we also have a Hermansky-Pudlak syndrome and Chidiac-Higashi syndrome, but these two are actually rare syndrome form of Delta SPD. Okay, Hermansky-Pudlak syndrome is basically a rare autosomal recessive disorder where this patient also have oculocutaneous albinism, and patient also have a bleeding manifestation as well. Okay, platelet dysfunction are present in all individuals due to absence of platelet dense granules, even though the platelet count is normal, and the blood smear usually show a pale platelet. Other than that, they also can have a pulmonary fibrosis, neutropenia, and immunodeficiency depending on the affected genes. For the Chidiac-Higashi syndrome, the clinical features include easy bruisings and bleeding. The white cell contain abnormally large cytoplasmic granules, and patient with Chidiac-Higashi syndrome also can have a oculocutaneous albinism as well. Okay, and this patient also can have a recurrent bacterial infection due to impaired immune function, and some individuals may have developed ataxia and neuropathies. For alpha granule SPD, what I want to talk today is about gray platelet syndrome. And as you all know, gray platelet syndrome derives its name from the gray appearance of the patient platelets in the peripheral blood as a consequence of the absence or ghostly of platelet alpha granules. Okay, the mode of inheritance also autosomal recessive disorder, and patient with this kind of a problem, we have a lifelong history of mucocutaneous bleeding. Okay, patient can have a mild thrombocytopenia with abnormally large platelets and isolated reduction of the platelet alpha granule contents. Okay, and the diagnosis is confirmed by electron microscopy. Maybe we will discuss later, and the quantification of alpha granule contents. Other than that, we also have a Quebec platelet disorder. Quebec platelet disorder actually autosomal dominant platelet abnormality, and this kind of patient can have a severe post-traumatic bleeding complication which are unresponsive to the platelet transfusion. At the same time, they have a deficiency of multimarin, basically one of the large protein that bind to factor 5 and its activated form. And because of that, patient with this disorder can have a very severe deficiency of platelet factor 5. Okay, and the platelet count is maybe reduced, maybe normal, and the platelet aggregation basically decrease with the epinephrine agonist. Okay, basically how to approach in this kind of problems. Okay, basically to approach and to manage this kind of patient, you need a history and physical examinations. Okay, history and physical examination are actually the key to to unlocking the diagnosis. Okay, certain type of patient they will have a certain characteristic or clinical features that actually can differentiate whether this is due to primary von Willebrand disease, okay, right, or is due to primary hemostatic disorder, or due to a secondary coagulation, or secondary hemostatic problem, which is coagulation disorder. Okay, the 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 three clinical features that always be used in to identify whether this is this. Basically, the first, patient with mucocutaneous bleeding, or patient with present with petechiae, for example, more towards primary hemostatic disorder compared to secondary, whereby patient with soft tissue bleeding or hematolosis are strong towards coagulation disorder. Okay, but in the setting of the injury or trauma, if a patient came with immediate excessive bleeding, it suggests to primary hemostatic disorder, because the initial plaque does not form correctly. Okay, they are unable to form the soft plaque. Okay, whereas delayed bleeding suggests a coagulation disorder, where it due to lack of well-formed fibrin clot, which result in gradual breakdown of the initial platelet plaque. Okay, right. So a patient with history of excess mucocutaneous bleeding warrant workup for primary hemostatic disorder, whether it's possible due to platelet, von Willebrand disease, or blood vessels, and for that uh, kind of patient, we need to start with taking the bleeding history. Okay, for that, there are actually standardized bleeding questionnaire that help to quantify information from the patient history and the family history, as well as examination, that lends important clues for potential syndromic and familial disease. Okay, so actually, how do you deal in case of patient with bleeding presentation? Okay, so bleeding assessment tool basically have successfully a standardized bleeding history, and it already proven to be a useful tools in the evaluation of patient with a suspected bleeding disorder. Okay, previously the initial BEPS actually studies focus on patient with von Willebrand disease. But subsequently, the International Society of Thrombosis and Hemostasis Bleeding Assessment Tool already validate in a cohort of patients with inherited platelet function disorder. Okay, and they actually demonstrate it useful.
Dia tak dapat dengar.
Tak dengar?
Okay, sekarang dah okay.
Okay, alright.
Maybe,
Yang ni sempat ke? Okay.
yang ni sempat
Right.
completed dah.
Okay, alright. So, as we all know that when they have a patient with mucocutaneous bleeding, so we need also exclude possibility of von Willebrand disease. Okay, and we know that von Willebrand disease and the test for von Willebrand functions is more accessible compared to other type of investigation. Okay, so when you need to consider to do a von Willebrand testing in a patient with a mucocutaneous bleeding, a positive bleeding score, and at the same time normal screening hemostatic evaluation, which is PT, APTT, and fibrinogen or thrombin time. So, basically, the typical pattern of bleeding in inherited platelet function disorder is mucocutaneous bleed. But sometimes you must you must you need to aware that patient with severe platelet dysfunction, for example, Glassman thrombasthenia, also can come with joint bleed. Okay, hence the diagnosis of inherited platelet function disorder cannot be ruled out based on the type of bleeding manifestation alone. Okay, you need to scrutinize everything before you conclude in certain disease or certain diagnosis. Okay, all right. In addition, some of the inherited platelet function disorder are associated with mild bleeding that does not reach the threshold for the possible positivity of the ISTH bleeding assessment tool. For this type of cases, you need to correlate back with the clinical presentation, whether this patient having an extra hematologic manifestation, for example, musculoskeletal abnormalities, or you have oculocutaneous albinism, and this basically a key in guiding the next step in clinical and laboratory evaluations. How about thrombocytopenia? How do you deal in this kind of patients? Okay, as we all know that that is actually widely accepted that platelet count less than 100 usually pathologic. Okay, and people with platelet count between 100 to 150 do not necessarily have a hematology condition. When a patient with a platelet count less than 150 times 10 power of 9 per liter, for example, and who actually always had a low platelet count, and they also have a family history of thrombocytopenia, or a patient with asymptomatic thrombocytopenia but diagnosed to acquired thrombocytopenia, for example, which not responded to a standard treatment, increase the probability of the inherited thrombocytopenia. Okay. Right. And in a case of thrombocytopenia, and at the same time, they had a family history of low platelet and myeloid malignancy, you need to think about inherited thrombocytopenia high in the differential diagnosis as well. Right. What about thrombocytopenia and increased bleeding? How do you want to go about? Okay. Some patients will present with low platelets and bleeding of proportion for the degree of thrombocytopenia. And in case spontaneous and severe bleeding disorder are rare cases of ITP. However, in case it can present with a bleeding manifestation if the platelet count drop significantly. Okay, so in a concomitant anticoagulant or use of antiplatelet agents and acquired coagulopathy increase bleeding risk at high platelet count. However, in a young and healthy patient, significant bleeding in the context of mild or moderate thrombocytopenia increase the probability of the inherited platelet disorder affecting platelet number and function. Okay, you need to think about the possibility of this as well. Okay. In terms of laboratory tests, which related to platelets problems, the initial investigation for a potential bleeding disorder should include full blood counts, a review of the blood film, okay, screening for INR, PT, APDT, thrombin, and screen for von Willebrand disease as well. Previously, we do a bleeding time, but this no longer recommended because this is just a crude method, okay, for initial work for platelet function disorder. Okay, right. And peripheral blood for patients presenting with thrombocytopenia, okay, the platelet indices can be useful in further increasing the test probability of an inherited platelet disorder. Okay, platelet size, which we report as MPV, okay, actually can help to distinguish inherited macrothrombocytopenia with a giant platelet. Okay, for example, in case of MYH9 related disorder and Bardet-Solier syndrome and ITP. Okay, they said that from if MPV is more than 12.4 pentiliter, the sensitivity and specificity is around 83% to 89%, which can distinguish an inherited etiology from the ITP. Okay, and despite the significant variation between MPV range, which report by the laboratories, the utility of this parameter remains significant in clinical practice. Some of the library, they do a platelet, mean platelet diameter, okay, where this mean platelet diameter may be more accurate measurement of platelet size compared to MPV. But this mean platelet diameter is not routinely performed, okay? Right. And significantly and consistently small platelet are the hallmark of the limited number of IPD that include viscohydration syndrome, okay, or ARP-C1b related thrombocytopenia. Okay, but in case of MPV with a normal range, basically is not really helpful in because a normal platelet size can be seen in a variety of inherited and acquired disorders. Apart from the MPV, okay, mean platelet diameter, okay, we also have the IPF. Okay, basically both ITP and IPDs, okay, inherited platelet dysfunction, in particular those presenting with macrothrombocytopenia will have an elevated IPF. And this parameter reported by some laboratories can actually used to distinguish them from the thrombocytopenia caused by acquired marrow failure. Okay, inherited platelet disorder tends to have high IPF compared to ITP. However, the range have significant overlap, and establishing a threshold with adequate sensitivity and specificity has been challenging. Okay, for those who want to do this type of IPF, which want to distinguish from the IPD or ITP, okay, you need to establish your own range to distinguish between inherited platelet dysfunction disorder or ITP. Okay, and sometimes abnormality in other cell lines can provide clues towards specific etiology of inherited platelet dysfunction. For example, IDA or iron deficiency anemia in a peripheral blood film is an indicator of the severity of the bleeding. Okay, some patient with microcytic anemia with an increased total red blood cell count could suggest acquired thalassemia in case of normal baseline, and maybe is can be seen in X-linked GATA1 related disorders. Okay. Some of the cases or some of the ETV6, for example, related thrombocytopenia, they have an elevated MCV. Okay, is basically elevated MCV is a characteristic toward ETV6 related thrombocytopenia. Okay, and when it comes with neutropenia, it can be seen in Hermansky-Pudlak syndromes or X-linked GATA1 related disorder and Wiskott-Aldrich syndrome related disorder, whereby patient with eosinophilia is characteristic of ARPC1B related thrombocytopenia. Okay. Basically, morphologic assessment of platelet and red cell by light microscopy is a useful and easily accessible process that can actually narrow the differential diagnosis. Patient with a dolly body, for example, okay, or a patient with giant white blood cell granules, for example, they can be is more toward for Chidia-Higashi syndrome, okay, and for Dory body in white blood cell, basically mostly or sometimes they with a MY H9 related disorder. Okay. Now we go to testing platelet function. Okay. Several tests to evaluate a platelet function are currently available, but access to specific testing methodology is variable across center and world region, with many laboratory techniques requiring fresh sample and large volume processing. Okay. Moreover, the methodologies has been difficult to standardize, and there still is great variation in result reported by different laboratory. Platelet function analyzer, for example, one of the platelet function testing actually often used as a screening test for abnormal platelet function, but it's not recommended by ASTH subcommittee on platelet physiology because of its lack of reproducibility and reduced sensitivity and specificity. Okay, the result do not offer a definitive diagnosis, and prolonged closure time are seen in patients with warm brain disease as well as those with a severe inherited platelet function disorder. Okay. And at the same time, the result will be affected by low hematocrit and low platelet counts. Okay. However, because of this device is still used in a diagnostic laboratory because of the widespread availability, low cost, ability to perform on low volume sample, and it's also automation and fast turnaround time. That's why this this device still one of the terkenal lah. Okay. So in the setting of suspected inherited platelet function disorder, a normal or minimally abnormal platelet function analyzer test can be used as evidence to suggest that the patient does not have a severe platelet function defects. Okay. And a normal PFA result does not rule out milder platelet dysfunction and need additional testing. Okay. Okay. In case of markedly prolonged PFA closure time, in the absence of severe anemia or absence of low von factors or absence of medication effect warrant further investigation that they could be due to severe inherited platelet function disorder such as Glassman thrombocythemia. Okay. What about LTA, large transmission aggregometry and whole blood impedance aggregometry? Basically, both these two, LTA and whole blood aggregometry, are the most widely used tests of platelet function. Okay, LTA, which consistently show abnormal aggregation with two or more agonists, actually has a high odds ratio in predicting bleeding disorder. Okay, LTA can be coupled with a Lumi aggregometry to measure platelet dense granule ATP release. The guideline of the standardization of LTA have been developed, and it is recommended method for evaluation of the inherited platelet function disorders, and it requires fresh and high volume blood samples. Okay, in pediatric patient, actually whole blood aggregometry overcome the sample volume issues, and but the reproducibility, sensitivity, and specificity have not been established. So usually whole blood aggregometry we do as a screen test, but to confirm we will go towards a PRP like LTA. Okay, and the greatest utility of the aggregometry is when a diagnostic or reproducible pattern is identified. This just to show you what's the pattern, the normal pattern of the aggregation, where you have a baseline, where you at this time you only have platelets, but after the addition of agonists, there are a slope there, and after that, because of the activation, okay, and shape change, everything, we start to release nucleotide granules, which produce a secondary wave. Right. Basically, decrease or absence aggregation with all agonists except ristocytin is more consistent to Glassman thrombocythemia, but it also can be seen in a leukocyte addition deficiency type 3, okay, because of variant infirm T3. Okay, to distinguish whether this is Glassman or LAD, which is leukocyte addition deficiency, it requires platelet glycoprotein expression quantification by flow cytometry. Basically, Glassman, there will be a deficiency or no reaction towards 2B3A, but LED, we have a normal expression of 2B3A. Okay. Normal aggregation with all agonists and absent with ristocytin is compatible with Bennett-Sollier syndrome. Although the severity of the thrombocytopenia can be seen in this disorder, may limit the ability to perform the aggregation study. So what we can do a platelet glycoprotein in this particular of cases, okay, to confirm the diagnosis. Some patients with Bennett-Sollier syndrome, they have a significantly low platelets. Sometimes they have a borderline normal platelet. Okay. And the absence of second wave with ADP, epinephrine, collagen, and only partial agglutination with ristocytin suggests a platelet storage pool disorder. Okay, and the diagnosis could be further supported by ATP release granule secretion. However, in some mild platelet function defect, in particular dense granular deficiency or abnormality, platelet aggregation may be normal or only minimally abnormal in large proportion of patients, and hence the result by itself does not completely rule out an inherited platelet function disorder. Right. When you have a increased agglutination with low dose vistocytin, is basically compatible with diagnosis of type 2B Willebrand disease or platelet type 1 Willebrand disease. Okay. And due to the impact of pre-analytical variables, basically abnormal platelet function result should be confirmed by repeating the test on a second sample. Okay, so to make sure the abnormality is persistent, and then only then you can diagnose with that particular problems. Okay. So when you have a platelet aggregation, but it's a normal aggregation, then actually you can exclude severe inherited platelet function disorder. When you have an abnormality with ristocytin only, then it's suggestive of Burnett-Sollier syndrome. And if there is abnormality with all agonists except ristocytin, that is suggestive of Glassman thrombasthenia. This platelet function test need to be repeated because to make sure that there is a sustained abnormality toward that agonist. Okay, so from after that you can consider platelet glycoprotein expression by flow cytometry, okay, to confirm the diagnosis. And if the platelet aggregation, there is actually no second wave in ADP, epinephrine, collagen, and or have a partial agglutination with ristocytin, is compatible with platelet storage pool disease. Okay, so this type of patient, you need to consider to do a platelet transmission electron microscopy and or do a granule release study. Okay. What about if there is a consistent abnormality with 2 or more agonists? They must be compatible with a platelet dysfunction, but not etiology specified. To do a platelet aggregation, you need to perform in patient with a normal platelet count or mild thrombocytopenia, which usually we accept if the platelet around 100. Okay, no medication known to affect platelet patient function as well. Okay, right. So this is example of the disorder and the example of the reaction towards agonist that you can actually look after this. Okay, right. For the flow cytometry, we have functional flow cytometry, and we also have expression of the glycoprotein flow cytometry. Okay, but functional flow cytometry basically based on the quantification of markers of platelet activation after the stimulation by different agonists. Basically is a highly sensitive tool in the study of inherited platelet function disorder, but it basically is more in a research setting because of the limitation of the requiring fresh sample, and because of the technical complexity, and also the cost, because the cost is very high. Okay. Simplified method has been developed but not widely available. Okay. Considering testing on platelet surface protein and structure, basically testing is to determine the platelet structural characteristic can be useful in inherited disorder of both platelet function and platelet number. For platelet glycoprotein expression, performed by flow cytometry, quantify the surface expression of the glycoprotein. And this test can be performed in low volume sample and can be shaped to a reference laboratory compare to yang tadi lah. Okay, right. So the most common expression that we do in the lab, expression that we biasa yang kita check is expression of GP2B, which is CD41, GP3A, which is CD61, GP9, which is CD42, and GP1B alpha, CD42B. To be okay. Some laboratories they have a GP6 and GP1A, which is CD49B. Okay, this test only detects quantitative and not qualitative deficiency in protein glycoprotein, and it is useful in confirming the diagnosis of Burnett-Sollier syndrome and type 1 or type 2 plasma thrombocythemia. Okay. Basically, this glycoprotein quantification is affected by platelet size, where with a platelet, large platelet, there will be higher expression of these glycoproteins. Okay, right. So this is just to show you what is a normal platelet. What is normal platelet looks like on the flow cytometry. Okay, the platelets which already selected, okay, based on forward and side scatter, and already circled in a green circle in green. Okay, and this platelet show they actually have a glycoprotein 2B positive for CD41 and glycoprotein 3A, which is positive for CD61. Okay. At the same time, the platelet also have a glycoprotein 1B, which is CD42B. Okay. Right. In a Glassman thrombocythemia, when we do a staining, and then that sample or platelets basically have a negative for CD41 and negative for CD61, okay, to 2B3A, okay, and but these platelets have a normal glycoprotein 1B, okay. This is a case of Glassman thrombocythemia. Okay. Now, just to show you again, a normal platelet has actually a normal expression of GP1B and 3A, okay, and also GP1B, okay. They will positive towards CD61, 41, and 42B, okay. But in this patient with Burnett-Sollier syndrome, the gated population in the dekat yang segi tu, and then after we add on the with the antibody 61 and 41, they actually has an expression of CD61 and 41, and but in the image, see that you that is shown here, basically there are population whereby there is no expression of 42, but expression with 61. This is the case of patient with Burnett-Sollier syndrome, which already transfused with a normal platelet. Okay, right. Okay. So what about platelet transmission electron microscopy? Okay, platelet transmission electron microscopy provide information on platelet structure as well as structure. Okay, and actually there are two types: whole mount platelet transmission electron microscopy and thin section platelet transmission electron microscopy. Okay, whole mount actually can is to look into a dense granules and thin section to look into ultrastructure plus the alpha granules. Okay, platelet whole mount transmission electron microscopy is the gold standard for the diagnosis of Hermansky-Pudlak syndrome and actually useful in identifying other causes of delta storage pool disorder such as Chigia, Ikashi, and Wiskott-Aldrich syndrome related disorder. Okay, so when you have normal dense granule, actually you can rule out dense granule deficiency, but in the whole mount, when there is decreased platelet dense granule, is compatible with platelet storage pool disease. Okay, and if the absence of platelet dense granule basically is compatible with a severe storage pool disease, for example, Hermansky-Pudlak syndrome and Chidia-Higashi syndrome. Okay. For the platelet transmission electron microscopy thin section, if you actually have a normal is actually rule out platelet as structural abnormality, and if you have a subtle abnormality, basically you need maybe it's compatible with inherited platelet dysfunction, but you need to repeat because it can be artifactual. Okay, and if you there is actually absence of alpha granules, there will be alpha granules deficiency. And if you see a large fuse alpha granules, maybe this patient is having a FLI1 related thrombocytopenia. And if you have a target like inclusion, it's maybe because of related to STIM1 related thrombocytopenia. Okay, now we go to genetic testing. Right, genetic testing is becoming widely available in the United States. Maybe we also know apa tu mungkin tak lama pun kita akan dapat this kind of testing. Okay, and basically in some cases the goal of genetic testing is to confirm a diagnosis established by platelet function or structural testing, testing problem such as Bernard-Solé syndrome and Glassman thrombasthenia. Okay, basically in genetic testing is a step in trying to identify the precise cause of an inherited platelet function disorder in which functional or structural tests are not as informative. For example, in Quebec platelet disorder. Okay, right. So a targeted familial variant analysis, usually they use a Sanger sequencing, is the simplest genetic test that is used in the evaluation of patients with inherited platelet dysfunction. It is highly cost effective when an affected family members actually have a confirmed diagnosis and the specific familial genetic variance is known. Okay, right. And next generation sequencing most effectively detect sequence variants and small insertion of the deletions, and the interpretation of genetic data and its correlation with the specific clinical context actually is a crucial step in the success of incorporating genetic analysis into a clinical care, right? And for this thing, basically we need the participation of genetic counselor who actually have expertise in setting a realistic expectation on possibility of the outcome of testing for patient and family, okay, in assisting the in test selection, for example, the communicating the result of testing and navigating incidental finding. Okay. There are actually significant ethical considerations as well when using a genetic panel. Okay, some patients incidentally have apa tu? Kita terjumpa apa tu germline predisposition, for example, in case ETV6 6 or RUN-S1, which require transparency and careful consideration of the indication for testing and need complete patient awareness and consent. Okay. So this is last two slide. Okay, basically diagnostic challenge and impact. The understanding the advantages, limitation, and expect the outcome of different clinical available tests to evaluate platelet structure, function, and genetic is important in maximizing diagnostic yield and obtaining information that is useful in guiding the management of patients with suspected inherited platelet dysfunction. Okay. And there is no testing strategy that is universally applicable as test selection will depend on patient age, concomitant medical condition, the agency of establishing the diagnosis and cost, okay, and many other variables that influence the medical practice. Okay. There also will be many patients with high probability of an inherited platelet function disorder in whom the exact etiology cannot be currently established. So the development of new testing methodologies, the growing number of the genes associated with inherited platelet dysfunction being described, with the increasing ease of the information sharing will set the stage for revisiting testing in this cohort of patients in the near and far future. With that, I think, thank you. Okay. Thank you, everyone.
Okay, terima kasih. Thank you, Dr. Safarina, for the extensive notes on the platelet disorders. Okay, finally we have come to the end. Any questions burning? We have come to our last session. Yeah.
Any question from the students? Okay, participant. Or maybe you need to go through this first, and if you have any question, maybe because it's inherited causes biasanya susah jugalah kan. And we have a lot of tests. Okay. Some tempat memang tak ada lagi test yang kita buat. For example, dekat biasa pun kita hanya buat platelet function test yang mana more toward aggregation test saja. Okay, kita tak ada lah untuk platelet adhesions, signaling, semua tu tak ada. Even flow pun kita tak ada. Tapi from I hope from this lecture you have as an overview regarding test yang ada and regarding platelet dysfunction as well. Okay, right. Because kalau yang quantitative tu mungkin you all boleh go about, and for inherited, that's why I more touch more on inherited causes today. Okay.
Okay. It's not an easy thing sebab banyak test tak available kan.
Betul.
Because we are over time kan, exceed time. Ada soalan daripada audience tak? Kalau tak ada, I would like to special thank to Dr. Safarina, okay, for conveying extensive notes on the platelet disorder. I think Dr. Saf also will share with us your PowerPoints kan?
Ya, betul, betul.
Okay, terima
Nanti
kasih.
if you have any question, you can boleh approach saya through WhatsApp, everything. You can come to me. Okay, right.
Okay, thank you for the
Yeah.
offer. Okay, to all the participants, thank you for patiently staying with us until the end. I really hope everybody has benefited from these 2-day sessions. And really hope that the knowledge that you gain will help you in your studies and also service. Okay. Don't forget to fill up the feedback forms for your e-cert. Okay, and we will email you the presentations from all the lecturers. Okay, all the lecturers have agreed to share with you all their PowerPoint presentation.